One of the kind of overarching questions that we've been studying is how do we choose between these different frontline immunotherapy regimens? And so we first looked in our paper in Nature Communications last year at the choice between IO mono and IO chemo. And what we found there is that it doesn't really look like chemotherapy is changing somebody's long-term outcome. And I think that's because it's chemo, it only works for 6 months, and then you progress. So what we really need for our patients is a more durable immunotherapy response. And I think when you add CTLA-4 in a subset of patients, you can help trigger that long-term durable immune response. But it also comes with the cost of significant toxicity, and I think as a community we're a little bit hesitant to give CTLA-4 if we don't think it's going to help. So it's increasingly important to understand what is the subset of patients in whom the risk of that toxicity is worth it because they may have that long-term benefit. When we've been looking at this in our data sets and in that poster at ASCO, one thing that stands out is that PD-L1 is really not as strong a response predictor for CTLA-4 as it is for anti-PD-1 inhibitors. So you can get very strong differential benefit from adding the CTLA-4 in low PD-L1 patients. Not, I think, because the PD-L1 is very predictive for the CTLA-4, but in fact because it's predictive to not respond very well to the PD-1, and you may or may not respond to the CTLA-4, but it might add that additional boost. So what we can see is that if you look across PD-L1 levels when you add CTLA-4, there is that subset of patients who have the long-term durable response. So if you want to say, well, who are the patients who don't respond to PD-1 inhibitor therapy alone? Maybe it's those low PD-L1. In our institution, we've also, as I mentioned, done a lot of work looking at STK11 and KEAP1, and this is work that's been really pioneered by Ferdinando Skoulides and John Haymack in my department. And they have a paper coming out in Nature later this year kind of honing in on STK11 and KEAP1 as well as being potentially preferentially sensitive to CTLA-4. And so that may be another subgroup where the immune milieu is such that the CTLA-4 inhibition is able to contribute in a meaningful way.